for tuning in to episode number 33 of the Doctor Podcast Show. I'm Dr. Robert Seichert. I'm your host today. Thanks very much for listening and watching. If you like the Doctor Podcast episode, which many people do, please subscribe and follow and like and also repost the episodes. We would really appreciate that. Today we're going to discuss a very important subject, and that is the subject of stroke. According to the CDC's latest data, stroke is the fifth most common cause of death in the USA. Approximately 163,000 people a year die from strokes, unfortunately. So it's a leading problem in healthcare. And today I'm very pleased to have as my guest a specialist in strokes. We have Dr. Laura Stein. She's a board-certified neurologist and an associate professor of neurology at the prestigious Mount Sinai Medical Center in New York City. And she also is one of the leading stroke specialists. Laura, thanks very much for coming today. I really appreciate you taking the time to talk to us about this. It's a very important condition, and I think the public has a lot to learn about it to try to prevent strokes and how to treat them and so on. So thank you.
Thank you for having me. It's both an honor and the public health importance cannot be overstated.
Right, thanks. So tell us how you got interested in medicine first and what led you to become a neurologist.
Sure. Well, I would be remiss if I didn't start with the story that my dad is actually a vascular neurologist. I am a proud daughter of one myself, and I guess growing up in a small town in Maine, I saw the immensely gratifying career he had caring for patients with all kinds of neurologic conditions, and specifically stroke. And I think witnessing that firsthand had a huge impact, whether it was conscious or subconscious. And then as I really explored medicine for myself, I realized that there was nothing as fascinating as the brain, and specifically the intersection of the brain with internal medicine in acute stroke care and the incredible evidence base and opportunity to help people from so many different walks of life with something so potentially devastating as a stroke.
So you kind of had medicine in your genes, right?
For better or worse,
right from the start. So after you went through medical school, you decided to do a neurology residency, right? How many years is that, the neurology residency?
So you do first a year of internal medicine and then 3 years of neurology training covering the whole spectrum of neurologic disease, inpatient, outpatient, and then at that point I spent a year doing subspecialty training in vascular neurology specifically.
I see. So where did you do your training?
Well, some people would call me a Sinai lifer, although I wasn't actually born at Mount Sinai, but I've been at Mount Sinai since medical school and have not left and have been immensely gratified in the opportunities that I've had there.
Yeah, Sinai is known for its great neurology department for many decades. It's a top place. So once you got interested in neurology, why did you pick the subspecialty of stroke within neurology?
You know, I trained at an incredibly pivotal time in stroke care. When I was a first-year neurology resident, so the academic year 2014-2015, we saw a complete transformation in stroke care. And in December of 2014, patients who came in with the most disabling stroke due to a blockage of a large vessel occlusion as we call it, were often left bedbound, dependent on the care of others. We weren't yet able to pull clots out because we didn't have the evidence that it was the effective treatment for these patients. Come January of 2015, midway through my first year of neurology training, we had a proliferation of really, really high quality evidence that thrombectomy, or pulling a clot out of these large blocked blood vessels, is incredibly effective for these patients. And so some of the same patients who might have been left bedbound and dependent on others in the month of December after January 2015 were potentially leaving our hospital or an acute rehab facility walking. And so it was just an incredibly transformative time to be caring for patients with stroke. I and my colleagues got very excited about how we could bring this revolutionary therapy to as many people as possible with the resources that Mount Sinai has. And then, of course, as I learned more about stroke generally, I learned about the incredible evidence base for all forms of stroke, and really sort of relished the opportunity to work with patients and their families at such an important time in their lives and to alter the trajectory going forward.
Fascinating history there. So you mentioned that there are blood clots. Those are blood clots in some of the blood vessels in the brain, because we know that the heart supplies two big arteries that go into the neck, the carotid arteries, and then those branch into the brain into various blood vessels. So the clots that you're talking about, those are blood clots that develop inside the brain?
That's right. The blood clots that I'm talking about are of these large blood vessels, either in the neck itself or in the head. Now, I'm talking about this, and I want to make sure I point out to the audience that large vessel occlusion stroke actually only accounts for probably around 20 to at most 30% of all ischemic or clotting stroke. So it's actually the small minority of patients who have one of these large vessel occlusions. Just so happens that the treatment we have for it is incredibly effective when patients can get to the right hospital at the right time. There are lots of other strokes where there isn't a blockage for us to pull out in those patients.
Right. So you mentioned ischemic, that means basically that there's not enough blood flow to the brain, and so the oxygen doesn't get to the brain, and the brain cells die actually?
That's right, yeah, and the brain is exquisitely sensitive to oxygen. In one of these large vessel occlusion strokes, in 1 second, while it goes untreated, 32,000 neurons die in the average person. Put a little bit differently, if that patient goes an hour without pulling large vessel occlusion out, normal aging is accelerated by approximately 3.6 years. So it has huge implications for patients when we are not able to restore blood flow in these large vessel occlusions.
Right. So what are the other types of strokes? You mentioned this accounts for maybe 20-30%, the large blood clots. What are the other types that can occur?
So there are two general types of stroke: ischemic strokes or clotting strokes, and hemorrhagic strokes or bleeding strokes. And we think about the cause of each type, and if it's not going to be a blockage of one of the big blood vessels, then it's very likely to be a blockage of a smaller blood vessel that comes off of them. What I, as a stroke neurologist, and my colleagues have to do is determine, well, where did that ischemic stroke originate? Did it come from the heart itself and a clot from atrial fibrillation, or from a weakened or a heart attack? Did it come from plaque buildup in the big blood vessels that either then traveled farther in the brain or didn't allow enough blood flow through? Did it come from damage to the small blood vessels? And then there are other things that are much less common, like did it come from spasm of blood vessels? Did it come from a tear in one of those bigger blood vessels? Did it come from a clotting predisposition in the body? For any number of things.
Right.
But what's really scary is up to a third of all strokes, we don't actually know the cause, where it's coming from. And so imagine being a patient and being told, we're not entirely sure why you had your stroke. There's high rates of recurrence and not a ton of certainty about the optimal way to treat those patients and prevent their future stroke.
But basically there's a blockage, no matter what type it is, it's a blockage of blood flow and a reduction of oxygen, and then the brain cells die. So
Yeah, that's an excellent
the
summary.
ultimate cause.
Yeah.
Now, you mentioned these blood clots. Let's say you identify that there's a blood clot, and so tell us how you decide if this is a blood clot that's blocking a major artery, or is it a bleeding in the brain? Because that would be very different how you treat that, right?
Absolutely. So our acute stroke protocol, which we hope every hospital in this country has in place, is set up to very rapidly assess clinically, do we think this patient is having a stroke? And what I mean by that is, do we think that there is an area of discrete damage to the brain that's causing obvious physical symptoms that's due to either the blockage or the bleeding? And so that's a clinical assessment based on talking to the patient, learning about their risk factors, examining them in a very focused and expedited fashion. And then we get, as quickly as possible, a CAT scan. It's like a 3D x-ray. It's done in seconds. very small radiation doses, and that tells us, is there bleeding in the brain? That's really our primary purpose, to see blood. It's very sensitive for blood.
So you can tell from a CAT scan right away if this is embolic or blood clot, or if it's bleeding in the brain.
Well, yeah, I mean, the most helpful thing is blood or no blood. What we hope, actually, is that it won't be a bleeding stroke, because we want to be able to give one of our acute treatments to reverse the effects of lack of blood flow. And we also hope that we won't see much evidence of damage to the brain tissue. We hope we're catching people as early as possible. Biggest take home for anyone listening is time is brain, okay, when it comes to acute stroke. And so we hope we won't see signs of a completed stroke. We want as normal of a CAT scan as possible, and then we use our clinical assessment to say this is acute focal neurologic problem due to impaired blood flow to the brain. And then we talk about possible treatments, thrombolysis or clot busting medicine, or if patients have a large vessel occlusion, blockage of the big blood vessel, which we see on, it's a CT angiogram, so it's like a 3D x-ray of the blood vessels, then we talk about clot removal, thrombectomy.
Interesting. So what are the causes of the hemorrhagic or bleeding stroke? You mentioned some of the causes for the blood clot. It could be from the heart, or maybe there's some plaque in the carotid arteries. Why would somebody bleed in their brain?
So the single greatest cause of actually both types of stroke is actually high blood pressure.
High blood pressure.
Yes, and we have a high blood pressure epidemic in this country. If we could just control high blood pressure, we could prevent so many of the strokes that we see. And so far and away, that is going to be the most common cause of hemorrhagic or bleeding stroke, which really only accounts for about 15% of all strokes that we see. And I will add, it is typically more disabling and causes more death. They tend to be very severe strokes for patients. We see other causes like being on blood thinners. Our population is aging, and atrial fibrillation is a common condition. People are on blood thinners, they may have head trauma. We want to make sure there's no problem underneath the area of bleeding, like an abnormal collection of blood vessels, like a tumor, making sure that there isn't something that sort of ruptured and caused bleeding that needs to be surgically repaired.
Right. So you mentioned time is brain, so time is critical and of the essence. So if somebody thinks they're having a stroke, or if a family member thinks someone is having a stroke, they shouldn't wait. They should call an ambulance, 911, right away. Is that correct?
I cannot emphasize enough, if you or someone you know could possibly be having a stroke, call 911 immediately, because we have only up to 4.5 hours to give our clot busting medicine in typical cases, and there's some exceptions to that we can certainly talk about. And we have more time to pull the clots out, but remember what we started with very early on, neuronal loss, cell death happens within seconds of an untreated stroke. And so we need to really do everything we possibly can to treat people as quickly and as safely as possible.
Right, so tell us, what are the symptoms that a person would experience if they're having a stroke, or if they're having a severe stroke, what would a family member or a friend notice when they're having a stroke, so that they know to call 911 right away?
Yeah, so public health campaigns use the acronym BEFAST, B-E-F-A-S-T, when it comes to signs of stroke. And it's for several reasons. One is we want you to act quickly and call 911. Right. Stroke symptoms typically come on suddenly. And we have limited time to treat patients when they may be having a stroke. But B stands for the sudden onset of problems with balance or coordination. At times patients may say that they feel like they're drunk even though they haven't had any alcohol. E stands for eyes, a sudden loss of vision or double vision. It can be a loss of vision in one or in both eyes. So you know all about vision loss. F stands for face, drooping or numbness of the face. A stands for arm, weakness or numbness. Same with the leg, although it doesn't have a letter. S stands for speech, problems speaking, problems understanding, problems communicating, sounding confused. And then T again for time, to call 911 and get treated immediately at the closest hospital capable of delivering the therapy that we now have for stroke care.
That's great to know. Be fast. Remember that.
Yeah.
So if you have any signs or symptoms, call an ambulance. Even though it might just be something else, but it's better to rule out a stroke real quickly.
Yeah.
So let's say a patient arrives in an ambulance at Mount Sinai and has typical symptoms of a stroke, a weakness of the arm or leg, difficulty speaking, cognition problems. What do they do in the emergency room for that patient?
Yeah, so what we hope is that there will have been an assessment by EMS that will have helped determine severity and actually will allow for calling ahead to say, we are bringing you this patient, meet us in the emergency department and sort of
Right.
activate your protocols.
So the people in the ambulance call and say, we think we have a stroke patient, and then the stroke team in the emergency room is ready for that.
Yes, and it's amazing how rapidly and how interdisciplinary this activated team is. It consists of emergency room physicians, providers, neurology trainees of various levels, nursing, CT, radiology, and basically everybody stops what they're doing to go assess this patient who may be having a stroke and may be eligible for this treatment. And of course, the emergency room physician has to make sure that they're just sort of stable from a blood pressure, heart rate standpoint. And
Right.
assuming they are, they really get whisked straight to the CAT scanner. And in the process, usually our junior neurology resident is very quickly assessing risk factors for stroke and as importantly, risk factors for bleeding, because that would be a reason why we wouldn't give the clot busting medication.
Right.
And then they're trying to make certain of what's called the last known well. And this is a concept that can be a little confusing for people, but it's really the time that the person was last their normal self and didn't have the deficits that brought them to the hospital. It's not the time that symptoms were discovered, it's really the last time that someone can verify that they were themselves and functioning at their baseline.
Right.
And so this is somewhat of it's a semi-controlled chaos. It happens very quickly, and you know the residents and team are assessing the patient on the way to the scanner, doing this quick focused exam. While the patient is getting this CAT scan, they're calling people, making sure that they know for sure when that last known well was,
Right.
and any reasons why they couldn't get a clot busting medication. And that's usually things around medications that increase the risk of bleeding. That's our biggest concern.
Right.
And then by the time the CAT scan's done, hopefully they can finish that quick exam and say, we're giving a clot buster or we're not.
Right.
And then after that, the CT angiogram is done to see if there is a large vessel occlusion that could be treated with the clot removal or thrombectomy.
Right, so you mentioned two ways to treat a blocked artery where there's no bleeding in the brain. One is these medications that are clot busters. Can you explain what that is and what the medications are?
Yeah, absolutely. So since about 1996, we've had medication that is abbreviated as TPA, or tissue plasminogen activator. Alteplase is the other name. And what this medicine does is essentially it binds to fibrin in clots, and then it promotes the conversion of plasminogen to plasmins. These are naturally occurring substances that promote lysis of clots. And we have to remember that these substances occur throughout the body, so it thins the blood throughout the whole circulature.
Right.
And so, we want it to get as close to the clot and have its maximal effect there, but it is thinning the blood generally. And we have, with traditional standards, 4.5 hours from that last known well to give it. But a couple things that are really exciting in our field have happened in recent years. The first is we're using a very similar version of tissue plasminogen activator, tenecteplase, that is a little bit more fibrin specific. It's much easier to deliver. We give it through the veins in one quick bolus over a minute, as opposed to a bolus followed by then connecting someone to an infusion and continuing it over a full hour. And it's probably just as good and safe, if not a little better, and easier to deliver than TPA all the places. So a lot of centers have switched to Tenectaplace, TNK is what it gets abbreviated as, and it's really streamlined systems of care, allowed for faster transfers from a hospital that doesn't perform thrombectomy to one that does, and people have had really good results with this medicine.
Is this available in most hospitals, or is it just major medical centers like Mount Sinai or NYU or Columbia?
Yeah, so that's a really great question. There are efforts from all kinds of national leading organizations to ensure that as many hospitals as possible are what we call acute stroke ready, so that they can, what we say as neurologists, drip and ship, give that medicine as quickly as possible, and then, as needed, send the patient to hospitals with more services for care. And there's been an incredible transformation of stroke care in this country over the past 20 plus years,
right.
And to the point that we're using even telestroke to help more under-resourced settings and make sure that an emergency room doctor has the support to very rapidly give this medicine and treat patients. So, it's not every single emergency department in this country, but we made huge progress and a lot of efforts afoot to continue that progress.
So basically the clotbuster drug just breaks up the blood clot that's clogging this blood vessel. The blood clot dissolves, and the blood can travel in the blood vessel and start delivering blood and oxygen back to the brain, right?
That's exactly right. Yeah.
So it's kind of plumbing. It's unclogging,
That's exactly right.
A stuck pipe or something.
Yeah, and what the studies have shown us is that these patients get the clotbuster. We look at their outcomes at 3 months, and they're more likely to have some degrees of functional independence than if they're not given this medicine.
Right.
And we typically give it to patients who are disabled from their stroke. Some strokes don't result in, not every stroke results in the same degree of disability, but when there is disability that's new from the stroke and they're within a treatment window, then we do really strongly recommend this medicine.
And the treatment window is about 4.5 hours. What if the patient shows up 7 or 8 hours later? Then it's too late to use
that's
that?
a great question. We have made a lot of progress in recent years, and I think thrombectomy has helped us move toward more of a tissue-based clock as opposed to a time-based clock. And what I mean by that is we can now use, in select cases, especially patients who come in after waking up with stroke, we use advanced pictures of the brain with an MRI or what's called CT perfusion to say, is there tissue that's at risk of dying but not yet dead? So I'll give you an example. Let's say a patient goes to bed at 10 p.m. the night before. They wake up at 9 and their caregiver discovers they're not talking, they're not moving the right side. They get to the emergency department by 10 a.m. the following day, so 12 hours from the last known well, when they went to bed. We can do a very fast and focused MRI scan and better assess that stroke within approximately 4.5 hours of the time that we're scanning them or not. And so if we don't see significant evidence of full complete tissue damage, then we talk about giving the clotbusting medication to a patient like that.
I see. And you mentioned another technique is to actually use a device to remove the clot. When is that used as opposed to the clotbuster drugs? And how do you insert this device into the blood vessel?
Yeah, so this has been really transformative for our field, even though, again, it's a minority of patients who have this type of stroke. But, we have up to 24 hours from the time someone was last known well, or we have to prove that there isn't extensive damage and that there's still tissue at risk of dying. And that's part of the nuanced assessment that stroke neurologists, emergency room physicians, and these interventionalists all make together in a team-based fashion. And so, the evidence for this therapy and indications keep growing. We're giving it at later time windows to people with clots in even farther locations that are harder to reach. The catheters that you talked about, where they feed it up through a big blood vessel in the leg and get all the way up past the heart and up to the brain, are getting better, and they are having really incredible results.
So it's a tiny catheter, and it has a device at the tip, and it actually can grab the clot and kind of pull it out.
That's exactly right. Yeah, it's incredible. And obviously, it goes without saying that the people who are performing this surgery are incredibly specialized, highly skilled proceduralists from all kinds of backgrounds, neurosurgery, neurology, radiology, and it's an incredible luxury to have this treatment. We take it for granted in New York City. There are 8 thrombectomy centers in Manhattan alone.
Really?
And if we contrast that
That's good
with
to know.
where I grew up in Maine, there's one for the whole state. And obviously population density is very different in New York City compared to rural Maine, but
Right.
it's a resource that we're very fortunate to have such ready access to here.
Now, if a patient comes in, had a stroke, and you do the CAT scan and it shows that it's a hemorrhage or a bleeding in the brain, then is there much you can do acutely for that?
Yeah, that's a really important question. So the first thing that we always do is control blood pressure. We want to prevent further expansion of the area of bleeding.
So the blood pressure causes the blood vessel in the brain to kind of break. It kind of...
Yeah, I mean, it's a huge driver of it, and then the brain gets irritated by the blood, and so that also drives the blood pressure up.
Right.
And so we safely lower blood pressure. We make sure there's no reversible cause of a bleeding tendency. So if someone's on one of the blood thinners I mentioned for, say, atrial fibrillation,
Right.
we can give medicine to reverse the effect of that. And we have to really very carefully manage the consequences of rising pressure in the brain. And so that's everything from, breathing status. Often these patients need a breathing tube and really aggressive supportive care. We try to minimize swelling and the effects of that with various consideration of fluids and other factors. And then a growing area of research is what group of patients may benefit from surgical evacuation through a growing range of minimally invasive techniques that
Right.
many of our neurosurgeons are pioneering, and they're trying to work out the question of timing in that. And this is an evolving field that's not the evidence base is not as clear as it is for thrombectomy yet, and so I think over the next several years we'll see great progress in that area as well.
Right. Now, one of the types of strokes that I get to see a lot in my elderly patients is a clot that's traveled into the eye, into the retinal blood vessels.
Yes.
It's known as a retinal artery occlusion. Sometimes I can actually see a cholesterol clot in a blood vessel. Or sometimes a patient will just have classic symptoms like I lost my vision for 15 minutes, it was totally black, and then it suddenly came back. When I hear that from a patient, I tell them you need to go to emergency room right away. And that's sort of a TIA or a transient ischemic attack. Can you describe that type of stroke and what patients should do if they have, let's say, sudden loss of vision that lasts a short period of time, or maybe they can't talk for 15 or 20 minutes? And then it comes back.
Yeah, so I'm so glad you're bringing up a couple important issues here. A stroke of the eye, retinal artery occlusion, is a stroke, and it can be very devastating for patients in terms of their visual function.
Right.
It can also be a sign of impending neurologic compromise affecting other parts of the body. And so we've come a long way, and we're again very fortunate here in New York City to have state-of-the-art care. So we actually have a retinal artery occlusion pathway where we get referrals from ophthalmologists like yourself, and the stroke code gets activated, hopefully in advance, and we try to make sure that these patients are within a 12-hour window of when their vision was last normal. And if they are, we offer select patients clot busting medication that's administered through the artery, directly to that location. And we've had some really great outcomes with that. Obviously, not everybody responds, and so people can be left with visual loss from it. But the reason it's so emergent is not only because we want to try to restore vision, but also we want to really quickly look at really the carotid artery and make sure there's not a
Right.
huge plaque and sort of impending compromise that needs surgical intervention very acutely. And then, just like any stroke patient, we assess all the risk factors and start really the same set of medications we do for strokes. Right?
I've had over the years many patients who came in with loss of vision that was transient, and I tell them we need to get you into the ER right away.
Yeah.
And several of them, or many of them, actually wound up having either occluded carotid arteries, or some of them had abnormal heart valves and didn't realize it.
Yeah,
and,
absolutely.
So we basically save them from having a stroke because the eye gave them a signal. So if you lose your vision for a few minutes, it's important. Don't just ignore it and assume it's a cold or something else.
And even like seconds. We hope that they're coming in with the transient form, or as we call it, amaurosis fugax, but sometimes they're not so lucky, and it is permanent vision loss.
It can be permanent vision loss. Yeah. And I've had some patients who were discovered to have atrial fibrillation, which presented as a vision loss in one eye. They had an arrhythmia, and then that was fixed. What about blood pressure? You mentioned is the leading cause for all of these strokes. Yeah. What other preventive measures can people do other than controlling their blood pressure? And blood pressure control is really critical. It reduces stroke incidence, heart attack incidence, and kidney failure, and multiple other things.
That's for sure.
But as far as strokes, what other things can people do to prevent strokes from happening?
Yeah, so by some estimates, as many as 80% of all strokes are actually preventable, which 80%. Is just staggering. And an ounce of prevention is worth a pound of cure. We're spending all this time talking about treatment, and the best treatment for stroke is to prevent a stroke. So I really want to emphasize that message to everybody, and that there is a lot you can do. What I would point people to is the American Heart Association has Life's Essential 8 for heart and brain health, and we'll see if I can remember all 8, but essentially they recommend that you eat better, exercise more, quit smoking or use of tobacco products, and I want to include all tobacco products.
The smoking damages the blood vessels, right?
Absolutely.
So they're more prone to bleeding.
Yep, and it's a big driver of plaque buildup and the carotid artery disease you were just mentioning. It really affects every organ throughout the body in very dangerous ways. Control weight, get healthy sleep, control blood pressure, control blood sugar, and control cholesterol. So those are the 8 things that really all of us can do, and I think it's really important to start small with any one thing that we're talking about, because if we set out to be overly ambitious with, say, our physical activity, then we're going to probably not be able to sustain the change that we've tried to make. So really good resources from the American Heart Association for healthy lifestyle habits and Life's Essential 8. Obviously working with your primary care doctor and other specialists to control any risk factors that you know that you have or that you don't know that you have, but uncover from routine screenings, and really empowering people to get physical activity in whatever forms they can, and think about simple lifestyle changes around diet as well as physical activity.
Right. Diabetes is another important issue. Also damages blood vessels in the eye and elsewhere in the body, so it increases the risk of stroke.
Yeah.
One thing you mentioned, exercise, that's really important. I've interviewed about 30 doctors now in multiple specialties. Every one of them tells me that exercise works for either prevention or treatment of whatever condition they specialize in.
That's for sure.
How does exercise do that? It reduces cancer, reduces diabetes, reduces stroke, reduces heart attacks, reduces depression.
That's for sure.
So
my favorite line is, exercise is the only wonder drug we have. Because there is no wonder drug except if it's going to be one, it is exercise. And
I like that.
Yeah, I really like that. So the CDC, U.S. Preventative Task Force recommends 150 minutes of moderate intensity or higher exercise per week, and 2 days of resistance training. And people may ask, well, what is moderate intensity physical activity? And that's an intensity at which you can talk but not sing. And if you're doing vigorous intensity, then those numbers come down to 75. But in my opinion, there's no upper limit to the amount of exercise, and I should be using the term physical activity we can get, because exercise comes in so many forms. Housework, dancing, various forms of socializing that are active are exercise and physical activity. And so again, talking about sustainable forms of physical activity in our lives. But going back to your question, it does so many things that
Right.
impact our stroke risk factor profile. And with hypertension being so important, we know that people who are physically active and potentially lose weight from exercise, that's a great, really effective at bringing down blood pressure. It really positively impacts all of the stroke risk factors that we've been talking about, and the mental health benefits, and then really the cognitive health benefits.
Right.
I think we're really just sort of scratching the surface of how big of a driver it is in all the things that you've outlined. And I don't think we have the best necessarily physiologic understanding. I'm certainly not an exercise physiologist to tell you or speculate about some of that, but the impact on both risk factor control, recovery from stroke, and prevention of stroke is just huge.
Right. You mentioned cholesterol. Many of my patients, I ask them what their cholesterol is because sometimes I see cholesterol deposits in the cornea.
Sure.
And some of them have pretty high cholesterols and they're not being treated. And they either say, well, I'm going to try, eating more lettuce or, trying to exercise. And my doctor said, let's wait a while. What do you recommend for people who have elevated cholesterols? I think LDL cholesterol seems to be the one that clogs up arteries the most.
That's right.
So when do you recommend treatment with a statin or other drug to lower the cholesterol?
Yeah, so unfortunately, most of my patients come to me after they've had a stroke, and so by guidelines, the American Heart Association, American Stroke Association have secondary prevention guidelines, and so we target an LDL or a bad cholesterol level of less than 70. And high intensity statins, they work. I think there is somewhat of a misconception about side effects with statins, and if you really look at the data, the side effects aren't necessarily any worse than people getting the placebo in a lot of these studies. And one of my greatest mentors said statins should be in the water because this is such a problem, and they have properties beyond just lowering an LDL around reducing inflammation, stabilizing plaque.
Right.
We have new PCSK9 inhibitors to complement statins, and so I'm a huge proponent of trying to get people below that LDL of 70 after stroke, and then following primary prevention guidelines for people who don't have stroke and initiating statins.
So if somebody has diabetes and high blood pressure, they haven't had a stroke, and their LDL cholesterol is 100, you would recommend they go down below 70, right?
Well, I typically don't do primary care, but using the ASCVD risk score calculator and following their very clear guidelines that give targets based on risk factor profiles. Right. And these medicines work, and that's another take-home message for the audience. Know your numbers. If you have any of these conditions, know what your goals are. Talk to your doctor about the options for getting those to those target goals, and really follow up to see that you're making the progress that you want to make.
Right. Very important. Now, what about patients who had, let's say, a clot and you busted it with the clot buster, or you got it out with a device? Do you put them on blood thinners after that to try to prevent this again?
Absolutely. So, as I mentioned, a big part of my job as a stroke neurologist is finding out that mechanism or cause, and so that really dictates our blood thinners. If we find atrial fibrillation, they're going to be on anticoagulation. If they have more damage to the small blood vessels, they're going to be on one or two antiplatelet medicines. A lot of progress with
aspirin or Plavix.
Yeah, those are the two most common, and growing indications to give a short course of two of them for approximately 21 days, especially in patients who have less disabling strokes that aren't thought to be from the heart. And so, for an ischemic or clotting stroke, all of those patients are going to be on some type of antithrombotic blood thinning medication, whether it's antiplatelet like aspirin or Plavix, or anticoagulant, which there are now many, but Eliquis is common.
Xarelto,
all of those.
Coumadin, warfarin.
That's right. Yeah.
So you decide which is best. Some of my patients are on both. They're on antiplatelets and also on Xarelto.
Yeah, and some of the patients who have hemorrhagic strokes end up needing to be on a blood thinner because, again, going back to the most common causes, high blood pressure can cause many of the hemorrhagic strokes that we we see.
Right.
And those patients who have high blood pressure and have hemorrhagic stroke often also have ischemic strokes. And so these are some of the nuanced decisions that stroke neurologists make with patients about maximizing benefit, minimizing risk. And so that's where you really want to know what type of stroke did you have, why does your doctor think that it happened, and what can you do to maximally reduce the chance of another stroke.
Do you ever put patients on low-dose aspirin if they have multiple risk factors for developing an ischemic type stroke? Or do you leave that to the cardiologist to do?
That's an area that has evolved over recent years. I think the evidence for aspirin and primary prevention to prevent heart attack and stroke hasn't really panned out. And so that's not being done as commonly these days. And again, I'm seeing people either after their stroke or in the context of, say, maybe a strong family history and education around that. And so, I very strictly follow sort of primary and secondary prevention guidelines, and they've really moved away from just sort of an aspirin a day with the hopes of preventing a heart attack or a stroke.
Right, because there's a risk of bleeding, which may be higher than the prevention benefit.
Yeah. And we really defer
that
to our
changes
primary
every
care
few
colleagues.
years. It's confusing.
And we would defer to our primary care colleagues who really know that.
Now, once a patient has had a stroke, if they have deficits, there's a huge role for rehabilitation, right?
That's for
Can
sure.
you tell us how you arrange that and how that occurs?
Yeah, so we work incredibly closely with our physical therapy, occupational therapy, speech and language pathology colleagues who are incredible. They meet patients, as soon after the stroke is safe, and work with them during the acute medical hospitalization and sort of have to balance things with their medical stability. And then our physical medicine colleagues evaluate for acute and subacute rehab. And I cannot overemphasize the importance of intensive physical, occupational, speech therapy, cognitive therapy. And we see patients look dramatically different 3 months after their stroke, 6 months after their stroke.
Right,
and
I've seen huge recoveries in my patients.
Absolutely. You often can't believe it's the same person who you met in the hospital bed before that. And so early, aggressive, intensive physical, occupational, speech therapy, cognitive therapy, all of that is just of immense benefit to patients and to their families.
Yeah. One of the things I've seen in many of my patients who've had strokes and tell me about is they go into a depression afterwards, which is understandable. Why? Is there a treatment for that, and what do you do for those patients?
Yeah, so unfortunately, post-stroke depression is incredibly common. About 30% of stroke survivors experience it at some point.
Do you think that's from brain damage or just the emotional stress or a combination of all those things?
It's likely a combination of all of them. There are multiple reasons why researchers feel that way. One is that we know that when you have damage to the brain, cell death, neurotransmitters change, neuroplasticity changes. The brain just doesn't function in quite the same way. We also know that adjusting to stroke is huge for people, and they go through a major process of at times grieving the loss of function and adapting to a new reality for themselves. And it's likely that interplay, because patients who have very minor strokes or non-disabling, I should use that term, non-disabling strokes and even TIAs can experience depression after their strokes, which is some support that it's not just the physical struggle, it's also perhaps what's happened to the brain and a very complicated response to everything the person's going through. But to get back to your question, there are very effective treatments, combinations of medications, psychotherapy, exercise like you brought up, cognitive behavioral therapy under the umbrella of psychotherapy, group therapy, and people. There's no reason to think that we can't get people back to where they were before. It just on us within the healthcare system to help people recognize and get that help, because fortunately I think it goes incredibly undertreated, and some of that is understandable given that it can be harder to at times elicit the information you need to make a diagnosis when people are having problems with their communication or their affects blunted.
Right.
And so what I always tell patients and their family members is if there's any change in one's recovery trajectory or anything that seems out of the ordinary for this person, bring it up to the care team, and every member of our healthcare community has a responsibility to really screen for depression after stroke, because not only is it so common, but it's associated with higher rates of recurrent stroke,
Really?
worse outcomes. It's really quite scary how much it can impact the course of someone's life if it goes untreated.
Right. So it's a team effort. It's you, the stroke doctor, the neurologist, plus the rehabilitation medicine doctor, the physiatrist, psychologist, psychiatrist, and
Yeah.
They all work together to make the patient better.
That's right.
You mentioned earlier sleep.
Yeah.
Sleep is in the news more and more.
It sure is.
Sleep, and it's almost like the opposite of exercise. It kind of
Yeah.
causes all the organs to fail if you don't sleep enough. Is
Yeah.
there good evidence for that, or how did you decide that sleep is a factor for causing strokes?
Yeah, so this is a very, it's an evolving area where we're learning more and more all the time. I think one thing that we've learned a lot about is sleep apnea as a risk factor for sleep and I'm sorry, for stroke, excuse me. And, that's through multiple mechanisms, including just worsening risk factors for stroke. We also know that breathing is altered, impaired after stroke, and probably contributing to trouble sleeping. And so we're seeing it on both sides. I think, I won't pretend that I'm a sleep researcher by any means, but we're just starting to really scratch the surface of the importance of sleep, both as a risk factor, the impact of, brain disease and brain health on sleep and related things after. So I'm sure we're going to learn a lot more in the coming years.
Yeah, sleep is a puzzling thing. The latest data I've read, and I'm interested in this, is if the ideal sleep time seems to be between 7 to 8 hours a night.
Yeah.
The data indicates if you sleep less than 7, your risk factors go up.
Mm-hmm.
If you sleep more than 8, they also seem to go up. So
Sure.
I set my alarm for 7.5 for now, but it's interesting that it has an impact on all these things.
Yeah.
What's your typical day like and work week like as a stroke neurologist?
Yeah, I guess part of what I love about my job is that very few days are the same. It depends on what my focus is for essentially the week. I sort of tend to go in week blocks. So if I'm on a stroke clinical inpatient service block, my day consists of reviewing cases from overnight, preparing to examine patients in various settings in the hospital, whether that's the ED, our inpatient stroke unit, or other units where patients are admitted with other medical problems and happen to have stroke. And I have the privilege of seeing all of these patients with big teams of trainees, from medical student all the way through, and at times high school student, all the way through, stroke fellows.
Right, so you do a lot of teaching of neurology residents. You're
I
an
do.
associate professor at Mount Sinai?
Yeah, and I'm one of the associate program directors for our residency. So I have a ton of very privileged interaction with trainees of various levels, which is part of what I love about my job. And so in those weeks, really my day revolves around seeing those patients, educating the patients and their families, and as importantly, educating our future generation of doctors, neurologists, and stroke neurologists. And then I have certain weeks where I'm more focused on research. I conduct stroke health services research, as it's called, really looking at disparities in both access to stroke care and outcomes for stroke care. I haven't used this line, but stroke is a disease of disparities. There are horrible disparities in incidence of stroke, recurrence of stroke, outcomes of all types based on so many different, social and structural determinants of health. So we have so much work to do around improving access and equity in stroke care, and I do really enjoy getting to be a part of teams that are trying to solve some of these problems and think about how we deliver care more equitably and effectively. And then, other days I'm more focused on residency, administration, developing curricular opportunities, mentoring, working in career development, and meeting the needs of sort of the modern learner. So I feel incredibly privileged to do all the things that I do and to have such stimulation and variety in my work.
Yeah, Mount Sinai seems to be in a unique geographic location where they can study the disparities, because if you go north of Mount Sinai, you have areas where the economy is not good, whereas if you go south, you have a more affluent type of patient. So you're getting both types of patients from north and south, so you can see the disparities and study them, right?
Yeah, and I think I've been really lucky in that my very rich clinical environment has always, and I hope and expect will always continue to inform the research that I do, and ultimately it's about bringing it back to the patients who we are failing, and there are so many, just given the fact that a quarter of the strokes every year are recurrent strokes.
A quarter are recurrent?
Yeah, a quarter. And there are so many patients who don't access acute stroke treatments all throughout our society.
Is that because they're not educated about the importance, or they ignore it, or what do you think the main reasons are for that?
I mean,
are we not doing our job as doctors in teaching these patients what to do to prevent this again?
Our systems are failing our patients in the sense that they're not adequately set up to help patients get the care that they need, whether that's the medications they need, the follow-up they need, the treatment in the moment when they're having symptoms that they may not be aware of. And I really put the blame on, us, the greater we in the healthcare system.
The system.
Yeah,
right.
and really the social and structural determinants of health that are more important than the, aspirin and the blood pressure medication that I prescribe so many patients.
Yeah, I see that also in my ophthalmology patients, some of whom have chronic diseases like glaucoma, and part of the big problem is just non-compliance with medications or follow-up visits, and even though we try to educate them, it's still a big issue. So I think that's true with many chronic diseases.
And a lot of work to do, for sure.
Right, got a lot of work to do. This has been incredibly educational and informative for me, and I'm sure for the audience as well. I think the most important thing I learned today is about the be fast thing.
Yes,
because many of my patients told me the story about their stroke or relative stroke. They kind of waited, they thought it would get better, they used cold compresses and things like that. So I think the critical thing is be fast, right?
I couldn't agree more. Time is brain, and even seconds of neurologic symptoms can be a sign of impending risk, and that risk is highest in the first 48 hours. So call 911, get the help that you need, and change the future course of what could happen.
All right. Thanks for coming today.
Thanks for having me.
I really appreciate it. It's been great. Thanks for taking the time.
My pleasure.
All
Take
right.
care.
You too.